Here we'll talk in a little more detail about how steroid hormones exert their effects. If you take a close look at this image, you'll see how the steroid hormone enters the cell and binds to its receptor shown here. Once bound to the receptor, it enters the nucleus and binds to DNA and affects gene transcription. The key here is that this type of signaling pathway is activated via modification of gene transcription, which takes time to occur. Therefore, physiologic changes that are mediated by steroids can take longer to take effect than something such as glucagon, which binds to an external cellular receptor which acts through second messenger molecules. A final note on steroid hormones relates to the concept of their lipophilic nature. As I said earlier, the fact that they are lipophilic allows them to cross the plasma membrane easily. With this knowledge, do you think that these molecules are insoluble or soluble in blood? Well, the answer is insoluble, and as a result, they may be carried by proteins known as binding globulins. Do you know what happens to the levels of binding globulins during pregnancy? Well, they'll increase. And why is this important to know? Well, it turns out that normally thyroid hormone is bound to thyroid binding globulin. And if the levels of thyroid binding globulin increase, then more of the free thyroid hormone will be bound. In order to compensate, the body makes more thyroid hormone, so that the unbound concentrations remain normal. The way that you could be tested on this concept is that you'll be given a scenario in which a pregnant patient has labs performed, and these labs come back with elevated T3 and T4 levels. Again, these are total T3 and T4 levels. But does this actually mean that she's hyperthyroid? The answer is no. This is because of an increase in thyroid binding globulin paralleling the increase in hormone production. As you'll see, that the amount of free T3 and T4 are unchanged. This is a really important concept for you to remember. So during the course of this lecture, we've mentioned thyroid hormone multiple times. Now we'll take some time to discuss it in more detail. The pathological conditions of hypo and hyperthyroidism are absolutely critical to remember for the USMLE. So it's important that you understand the physiology as well as the pathology. Thyroid hormones are produced in follicular cells of the thyroid gland. Thyroid hormone acts to increase the body's basal metabolic rate. It is important to understand how these hormones are made, so you can better understand how our pharmacologic approaches to hyperthyroidism work. The main component of this hormone is iodine, but how does it actually get made? You can see in the diagram that iodine ions from the blood are taken up by follicular cells and become oxidized to I2. They are then secreted into the lumen, and that is shown here. The process of oxidation is catalyzed by thyroid peroxidase. Meanwhile, within the follicular cell, thyroglobulin is being produced and secreted into the lumen. Thyroglobulin, or TGB, serves as the backbone of thyroid hormone and contains many tyrosine residues. These tyrosine residues are where iodine ions get attached, and this is through a process known as organification. This reaction is catalyzed by the same enzyme just mentioned, thyroid peroxidase. Next, iodinated thyroglobulin is brought back into the follicular cells and is digested by lysosomal proteases to release monoiodotyrosine, MIT, and diiodotyrosine, DIT, into the cytoplasm. Combining MIT with DIT results in triiodothyronine. Think mono, which stands for 1, plus di, which stands for 2, makes 3, or T3, that is. And I'm just going to write this out right now. MIT plus DIT equals T3. So how would you generate thyroxine, or T4? Well, in this case, you combine two DIT molecules. DIT plus DIT equals T4. The process of combining these molecules is known as coupling, because, as you can see, we only use combinations of two molecules of T3 and T4, and this process is catalyzed by thyroid peroxidase. So remember that thyroid peroxidase is associated with oxidation, organification, and coupling of MIT and DIT. It's worth pointing out that T4 is a major product of follicular cells, while T3 is the active form of the hormone and is mostly made in target tissues. This occurs via deiodination, or removal of the iodine group from T4, which is catalyzed by 5-deiodinase peripherally. Let's now turn to the functions of thyroid hormone. As already noted, the major role of thyroid hormone is to control the body's basal metabolic rate. So how does it do that? In brief, thyroid hormone increases sodium-potassium ATPase activity and expression, which increases oxygen consumption, the respiratory rate, and body temperature. It also upregulates glycogenolysis, gluconeogenesis, and lipolysis to increase ATP production. A really interesting feature of this hormone is its effects on target tissues and receptor expression. First, do you know what are some of the cardiac symptoms of hyperthyroidism? Well, people can have palpitations and tachycardia. Now, what type of receptors are found on the heart which, when stimulated, lead to this increased heart rate? Beta-1 receptors. Now, what thyroid hormone actually does is that it upregulates the number of these receptors, meaning that the heart becomes more sensitive to circulating epinephrine and norepinephrine. And this is why we see an increase in heart rate, stroke volume, contractility, and cardiac output. There are two critical functions of thyroid hormone in the developing body. It promotes bone growth and the development of the central nervous system. This is why, in the case of neonatal hypothyroidism or cretinism, you have severely stunted physical and mental growth, for example, short stature and low IQ. You may find it helpful to think of thyroid hormone in terms of the 4 B's: brain maturation, bone growth, beta-adrenergic effects, and increased basal metabolic rate. Also, make sure you don't confuse TBG, or thyroxine binding globulin, a carrier of thyroid hormone in the blood, and TGB, or thyroglobulin, the precursor of thyroid hormone. Flash quiz. Do you know what is the most common cause of neonatal hypothyroidism in developing countries? In developing countries, dietary deficiency is the most common cause. This is due to a lack of iodine. Note that in developed countries like the United States, iodine is added to table salt, so dietary deficiency is quite rare. In developed countries, thyroid dysgenesis, which means abnormal growth during the embryonic period, is the most common cause. Be careful, because examiners love to ask you about the developing versus the developed world. So be sure to read the question carefully. Okay, now to close out the physiology section, let's do a board-style question. A 30-year-old woman reports no prior medical history and is diagnosed with diastolic hypertension. The patient reports symptoms of weakness, fatigue, polyuria, polydipsia, and headache. Laboratory results indicate that she is hypokalemic and hypernatremic and has decreased renin levels, and has a metabolic alkalosis. CT of the abdomen shows a 4 cm mass located in the right side of the body. In order to immediately relieve this patient's condition surgically, the surgeon must first ligate the primary venous drainage of this mass. Pause the video while you think about the answer, and when you're ready, hit play. The answer is the inferior vena cava. First, let's review why this is the case. Number 1, we had to make the diagnosis that there is an aldosterone-secreting adrenal tumor. We could make this diagnosis based on the fact that the patient has high sodium, low potassium, and metabolic alkalosis, which can occur as a result of high aldosterone levels. If you do not recall the function of aldosterone, be sure to review the renal section, as this concept is very important for you to master. Suffice it to say for now that aldosterone promotes the resorption of sodium and increases the excretion of potassium and hydrogen at the collecting duct. We know that aldosterone is made in the adrenal glands, and we have on the CT a right-sided mass, so it is likely that an aldosterone-secreting adrenal tumor exists. Now that we've made the diagnosis, Conn syndrome, we have to focus on the drainage of this right-sided adrenal mass. You should remember that the right adrenal gland drains directly into the IVC. Thus, that is where we ligate. Remember, boards is all about how you apply the knowledge you have. So even though you may know the drainage of the adrenal gland by heart, be sure to do questions so that you can see how they ask you for the information that you have learned. A great resource are your USMLE RX questions. And that concludes the physiology section. Next we'll move on to pathology, where you're going to apply what we've just learned to what we see in patients. Give yourself a little break since we've covered a lot of material, and come back refreshed and ready to learn more.